on anesthesia in pediatric cataract by Dr. Dwideep Chandra, who works at Comtrust Eye Hospital, Calicut.
So today we are covering perioperative management of pediatric anesthesia with respect to the ophthalmology. Now, we know that these kids are not a miniature form of adult, so we need to know what are the differences between the pediatric group and the adult. We know that their cardiac output is heart rate dependent, and the decrease in preload, increase in systemic vascular resistance, and decrease in heart rate are poorly tolerated by these kids. Looking at the respiratory system, these kids are obligate nasal breathers that will help them in breastfeeding, whereas the diaphragm and intercostal muscles do not achieve the adult configuration until the age of 2, and the narrowest portion of their respiratory tract is the cricoid cartilage. Also, this postoperative GA, postoperative apnea is very common in premature and anemic infants, because the adult respiratory control will not achieve until 44 weeks of post-conceptional age. And alveolar formation continues up to 18 months of age. And renal and hepatic system, complete maturation occurs at 2 years of age. And these kids have minimal ability to shiver in the first 3 months. So we have to heat the whole body, including the head. And we have to cover the babies from head to foot. So why this pre-op evaluation is mandatory in these kids? We know that this cataract, strabismus, glaucoma diagnosis in kids is associated with the underlying diagnosis of some or other syndromes. And these syndromes can cause different anesthetic issues, including the difficult airway, difficult face mask ventilation, and many cardiac lesions. And these neonates, including premature and ex-premature neonates, who is associated with a congenital cataract, we have to deal with neonatal anesthesia and their glycemic control, temperature management, and as I said earlier, the chances of apnea of prematurity, and they have this bronchopulmonary dysplasia. So what are the ASA recommended minimum mandatory workup in these kids? ASA recommend that a CBC serum electrolytes, RBS serology are mandatory in these kids, and we need to screen their renal function with the serum creatinine and liver function with SGOT and SGPT. Echo is needed to rule out congenital anomalies, cardiac anomalies, and most of the kids are sepsis survivors. So it is prudent to see if their CRP level came back to the normal level before accepting for anesthesia. So I wanted to address few of the myths about intraocular pressure and anesthesia. This is one of the most interesting thing. Like, is your anesthesiologist making your surgery difficult? So we see this question asked to me every time when I give a pediatric case. So we know that most of our induction agents and volatile agents reduce IOP except for ketamine. Whereas nitrous oxide, opioids, atropine, and ondansetron does not have any effect on intraocular pressure. Whereas ketamine is concerned, the increase in IOP occurs when the doses crosses 5 milligram per kg. Below that, there is very little effect on intraocular pressure actually. But our succinylcholine or scoline definitely increases intraocular pressure up to 8 millimeters of mercury, and it lasts for around 10 minutes. So, on the contrary, are your medication making the anesthesia difficult? Yes, indeed. We know that beta blockers, prostaglandin, and NSAIDs all will cause bronchospasm in susceptible asthmatic kids. Beta blockers also causes bradycardia, and acetazolamide, carbonic anhydrase inhibitors, causes mild hyperchloremic metabolic acidosis. They are prone for nausea, and these drugs promote renal loss of electrolytes and water, which will result in arrhythmias intraoperatively. And our local anesthetic agents can cause local anesthetic systemic toxicity, mainly in premature infants. Also, our sympathomimetic agents like phenylephrine, which is used to create a pupil dilatation, causes tachycardia and hypertension. Now, coming to the individual anesthesia procedures, one of the most common thing is examination under GA and measurement of intraocular pressure. We prefer inhalational induction with the ophthalmologist ready to measure the IOP as soon as the child is asleep and the eyes are central. We can manage the airway with a face mask or an LMA, but IOP should be ideally measured before any airway manipulation to avoid artificially high readings. And we keep our anesthetic techniques consistent because these children may return regularly for repeat measurement of intraocular pressure. Now coming to the glaucoma, the most we have to screen for associated syndromes and anomalies. A spontaneous breathing technique is most commonly used. We use monitored anesthesia care, IV sedation, or GA with a spontaneous respiration. And we use synchronized and intermittent mandatory ventilation. Same way, pressure control ventilation modes, and CPAP, that means continuous positive airway pressure modes for our children, which is far better than unmonitored back ventilation. We avoid ketamine and scoline in these kids. So coming to cataract, we have discussed most of the things already. The anesthesia should provide a motionless eye and aim for a smooth emergence. Thereof, crying and struggling babies post-emergence is long gone. Coming to the strabismus surgery, the strabismus surgery has the highest incidence of exhibiting oculocardiac reflux and post-operative nausea and vomiting. The strabismus surgery is very painful, and we use judiciously opioids and other analgesic intraoperatively. Postoperative analgesia is managed by paracetamol or NSAIDs, along with the topical local anesthetic eye drops. Ocular myopathies have been rarely associated with the malignant hypothermia, so we avoid using scoline in these kids. Also, we institute temperature monitoring. Coming to the oculocardiac reflux causes profound bradycardia. Very rarely this may result in sinus arrest. The cause is pressure on the globe or traction of the extraocular muscles and mediated through the trigeminal efferent and vagal efferent. It is more common in children because of their higher vagal tone. It can occur with a strabismus surgery, enucleation, vitreoretinal surgery, or orbital surgery. Basically, any pressure on the eyeballs can precipitate OCRs. The surgeon should be asked to release the traction on the eyes or the muscles or the pressure of the globe when this occurs, and a pre-filled syringe of atropine and glycopyrrolate should be readily available to treat the bradycardia. Coming to the postoperative nausea and vomiting, most of the ophthalmic surgery is emetogenic, and the risk of PONV increases above the age of 3. And Association of Pediatric Anesthesiologists of Great Britain and Ireland recommend that dual therapy should be given with ondansetron and dexamethasone preoperatively to reduce the incidence of PONV, and a rescue therapy with a different agents such as droperidol or in the postoperative recovery room. Coming to the blocked nasolacrimal duct, usually it's a short procedure with the patient breathing spontaneously over an LMA. While these procedures can be more complex with the installation of saline and fluorescein. And in that case, we place a suction catheter in the nose or nasopharynx to prevent aspiration as well as to detect the dye getting instilled into the nasopharynx. This surgery as such is painful, and we use opioids. Bleeding from the nasal mucosa, Bleeding from the nasal mucosa can be ameliorated with our topical vasoconstrictor like Otrivin or Nasavion. This will prevent postoperative dribbling and postoperative aspirations. We keep throat packs intraoperatively to protect the airway from aspiration. At the end of the procedure, airway should be suctioned under diet vision to remove any clots and debris. Coming to the retinoblastoma, these children recur multiple GA sessions as frequent as every 4 to 8 weeks. And they undergo intraarterial chemotherapy, and one of the most common problem associated with intraarterial chemotherapy is myocardial stunning, which can occur up to 40% of the patients. So atypical bronchospasm is very common with this treatment. So we need to review the previous anesthetic charts for complication before accepting the retinoblastoma patients for EUA or further procedures. Coming to the ROPs, retinopathy prematurity, there are different methods like cryotherapy, laser photocoagulation, and anti-VEGF monoclonal antibody injections. Out of this laser photocoagulation is tolerated well under local anesthesia. In selected cases, in certain centers, laser treatment is done under sedation and local anesthesia in NICU. We can give oral sedative like chloral hydrate. Also a subtenon block will help. When general anesthesia or sedation is necessary, the concerns regarding respiratory and cardiovascular prematurity, hypothermia and hypoglycemia should be considered. The theater temperature should be increased to at least 25 degrees Celsius and active farming is used. The procedure can be prolonged and if opioid analgesia is used, many of these infants will need postoperative ventilator support in NICU. Thank you.
That was sharp on time. Thank you, Dr. Dwideep, for that wonderful coverage of all possible anesthesia procedures in pediatric ophthalmology.